So it's my pleasure to introduce Dr. Julio Garcia-Aguilar. His impressive resume includes over 130 research articles and 75 review chapters, along with service on several editorial boards of prominent journals, such as the Annals of Surgical Oncology, the Diseases of Colon and Rectum. Currently, he serves as the chief of the Colorectal Service at Memorial Sloan Kettering, where he leads a highly skilled group of 8 surgeons overseeing both clinical operations and groundbreaking research. So his dedication to mentorship and focus on education make him a real pleasure to work with, as I know, and I'm very excited to hear his insights on total neoadjuvant therapy and rectal cancer today. So with that, I'll turn it over to you.
Jordan, thank you so much for your generous introduction, and thank you for the invitation to participate in this event. As I was saying, you guys need to be commended for deciding to start an initiative like this on Sunday night when most people will want to be having dinner with family or watching football or whatever. But it's a pleasure to be here. What I'm going to do today, I'm going to give you kind of a personal vision, which might not be the most conventional one, about neoadjuvant therapy in rectal cancer, and I will touch base a little bit of organ preservation and the most recent trials, including the use of immunotherapy in MMR deficient tumors. So I think I'm going to start just by, this slide, we cannot represent what has been the standard practice for the treatment of patients with locally advanced rectal cancer for years, essentially since the German trial that's kind of settled the debate between preoperative and postoperative chemoradiation for rectal cancer. This was the standard for most places in the United States and in other places throughout the world. The issue with this treatment is that provides excellent local tumor control, but it causes significant morbidity, organ dysfunction, the LAR syndrome that you are familiar with, and other problems, sexual and urinary dysfunction that impair the quality of life of the patient permanently. The other problem left with this treatment is or was the risk of developing distal metastasis. Again, as surgeons, we focus a lot in local tumor control because we feel kind of responsible for that. And a lot of the emphasis in rectal cancer has been to control the disease locally. When I was a resident, the rate of local recurrence was 30% or higher for patients with locally advanced disease. And over the year, it has gone down drastically. But at the end of the day, most patients who die from rectal cancer die from distal metastasis. So these were the two challenges that we had in the last couple of decades in rectal cancer. So improve survival and preserve the quality of life whenever possible. We have been making improvements in organ preservation, but that's not always associated with improving on the quality of life because of the sometimes bad syndrome, LARS and urgency and frequency and clustering and all the constellation of symptoms that follows a low anastomosis. So, without new medications to reduce the risk of distal metastasis, the only thing that we could have done really was to improve the compliance with the current chemotherapy that we have. 5-FU and oxaliplatin, they have been around for a while. We haven't had any breakthrough really that has provided dramatic improvement in survival for most patients. There have been some subgroups that might have benefited from this or that, but really we have been kind of stuck with fluorouracil and oxaliplatin for the last 30, 40 years. And in terms of preserving the quality of life, eliminating potentially unnecessary treatments, we use many treatments that sometimes can be eliminated if we select the patients properly. And that includes eliminating radiation, sometimes eliminating chemotherapy, and sometimes even eliminating surgery, because we know that with the chemotherapy and radiation, there are some patients that go to the operating room, have the rectum removed to find out that there are no cancer cells in the specimen. So those have been the areas that we have been trying to improve both survival and the quality of life of the patient. Now, one of the components, the component that has been a little bit more controversial in the 3 modalities used in rectal cancer has been the adjuvant chemotherapy. And I'm going to touch a little bit upon that. The use of chemotherapy in rectal cancer has been based on the fact that 25% of the patients develop metastasis and is the leading cause of death. And we have extrapolated a lot from colon cancer. We assume that rectal cancer is biologically similar to colon cancer, and if systemic chemotherapy has been proven kind of unequivocally that reduces the risk of distal metastasis in patients with stage 3 colon cancer, we assume that this should also work in rectal cancer. But the evidence in rectal cancer is much weaker than the evidence in colon cancer. In fact, a meta-analysis of individual patient data from four prospective randomized control trials that has used chemotherapy, no chemotherapy in rectal cancer really failed to show any significant improvements in overall survival. So, for example, in Europe, in the Netherlands, in other countries, chemotherapy were not part of the treatment of patients with locally advanced rectal cancer that had already received chemoradiation or radiation therapy. Again, that's also a big distinction when we think about chemotherapy in colon versus rectum. Colon don't get radiation, rectal cancer, they do get radiation and sometimes some chemotherapy. So that's the debate in Europe. Many surgeons and oncologists felt that if you have received radiation therapy, chemotherapy had not much to add in terms of overall survival. Now, the criticism to these studies, including this particular meta-analysis, is that the chemotherapy regimen used in those trials was a little bit outdated, and also that the compliance with the systemic chemotherapy was low, because when you get chemotherapy after rectal cancer surgery, many patients had stomas, had complications, are debilitated by the surgery, and they do not start the prescribed systemic chemotherapy. And of those who start the prescribed systemic chemotherapy, very few really complete the intended 4 months that it was usually commonly done. So, there have been debate about this topic in both sides of the Atlantic. We were more in the camp of giving chemotherapy if the patient can tolerate it. In Europe, they were not. Now, here is where we came with the idea of total neoadjuvant therapy. I mean, we believe that systemic chemotherapy is beneficial to patients with rectal cancer, and they had difficulty getting the chemotherapy after surgery. Why not give the chemotherapy before? So that's where the whole thing started. And, the hypothetical benefits are known. You improve compliance. You treat earlier subclinical metastases that, in the conventional treatment with chemoradiation, surgery, patient recovery, and then chemotherapy, it takes several months before the patient sees any meaningful systemic chemotherapy to treat the micrometastases, who at the end of the day are, what kills the patient. Also, chemotherapy before surgery might further enhance the primary tumor response. And not so important to us, but probably important to the patient, giving the chemo before kind of shorten the time that the patient needs to have the ileostomy. So that was the rationale for the TNT, for starting chemotherapy before surgery. And this can be done in 2 different ways. You start with chemotherapy, and these are the advantages that we have mentioned before, or you can start with chemoradiation first. In addition to some of those advantages, we believe that increases the tumor response even more. So there have been both approaches. I must say that the idea of starting with systemic chemotherapy is probably older. It started many years ago with a number of phase 2 trials, started in the early 2000s, when oncologists started to give a variable number of cycles at the initial treatment of patients with locally advanced rectal cancer, with the idea of enhancing the response and probably improving survival. These studies, for the most part, they failed because they did not increase response dramatically. They didn't increase survival. I think what we learned from those trials was that starting systemic chemotherapy right away, which you can start almost immediately after diagnosis, provides significant symptomatic relief for the patients. And that was one of the advantages of starting chemo. You don't need to do simulation. It's something that you can start with even a peripheral IV early, after diagnosis, and it's something that can be done very rapidly. Now, at MSK, we adopted this approach very early on, and we published a number of years ago a retrospective analysis of our own experience, and what we found was that yes, systemic chemotherapy is better tolerated when you give it before surgery, and enhances the tumor response. Also shortens the time for the ileostomy. So better tolerated by the patients, enhanced response, and shorten the time of ileostomy. The only thing is that when we look at survival, the difference was not that significant. Starting chemotherapy before chemoradiation and surgery did not increase survival significantly compared to the standard practice, even though the compliance with the chemotherapy was better in the patients treated with the so-called TNT and got a higher dose of the prescribed chemotherapy. There have been no really prospective randomized trial that have compared these two approaches, the standard chemoradiation surgery adjuvant chemo with induction chemotherapy, chemoradiation, and surgery. This is a small study that was conducted in Europe, and they randomized only 108 patients. So the number of patients in each arm was very small. Again, compliance with induction chemotherapy was much better than compliance with the chemotherapy, but in spite of patients receiving more chemotherapy in the TNT arm, survival was similar in both groups. So this kind of chill out things a little bit. Again, this idea was pursued in other trials, and probably one of the most famous ones that has been published in the last 4 or 5 years is the PRODIGE 23 conducted in France. In this study, they use not really the TNT that was used in the previous study, where you compare the standard treatment with chemotherapy, chemoradiation, and surgery. In this study, they introduced 2 different changes. One, in the control arm is the standard control arm, radiation, TME, and FOLFOX in the upper blue line. In the bottom, we represent the experimental arm. They started with 3 months of FOLFIRINOX. So to FOLFOX, they added also irinotecan that hasn't been used systematically in rectal cancer, then chemoradiation, then surgery, and then more chemotherapy afterwards. So this was a little bit of a different design than what we have been doing historically at MSK and in other places in the United States. The response rate was higher in the experimental arm. The disease-free survival in the initial publication was better in the experimental arm. The overall survival was the same. What is important to understand is that the lines separate a little bit, but they separate very early on, even before the patients started the follow-up beyond the treatment. And I think that's important to look at the details, because otherwise people might reach different conclusions. When you look at the number of events in both arms, what was striking is that the number of patients who die during the hospitalization was 0 in one arm, and it was, higher in the standard arm. And there is not an explanation for that. And that's probably that bump in the mortality in the experimental arm, in the control arm, in the blue arm. See that point in there? That probably represents those patients who die early on, and probably have nothing to do with the effect of the chemotherapy in the metastatic disease. But I think you have to look at the papers in detail before reaching a conclusion. So with longer follow-up, they suggest that survival might be a little bit better, but the cancer-specific survival is still no different. So I think this study is at least controversial in terms of whether the experimental treatment increases disease-free survival and overall survival or not, because as I say, the curves separate very early on, as we will see in a different trial a little bit later, and that is what is carried through the rest of the follow-up of the patients. So this is the most recent data. Again, with longer follow-up, the curves are still very much the same, separate early on due to events that happened almost at the time of the surgery, and then the curves run parallel for the rest of the survival. What is clear is that if you use more chemotherapy, you get more acute. In the experimental arm, you have toxicity during the induction chemotherapy, and then during the adjuvant. In the standard arm, you only get chemotherapy at the end, so you skip the additional toxicity that the patients experience with the induction chemotherapy. So I think in terms of what is the summary of the evidence in induction chemotherapy after or in patients treated with chemoradiation? Well, increases the rate of tumor response, improves compliance with systemic chemotherapy, seems to reduce the rate of distal metastasis and improve survival with a sandwich chemotherapy regimen that also includes irinotecan. But I think we have to take all the data with a grain of salt, because there are a number of events that count for the survival that they are not very well explained. Again, particularly the mortality, the perioperative mortality in one group versus the other, when they have received at the point of the surgery similar chemoradiation and chemotherapy. So now we're going to look at the other approach, start with chemoradiation first, and then give systemic chemotherapy after. And this is the study schema of a trial that we conducted a number of years ago. It was called the timing trial, because what we were interested was in seeing the rate of response that could be achieved by lengthening the interval between the end of chemoradiation and the time of TME. And because in the United States, we couldn't have a very long interval after chemoradiation without systemic chemotherapy in patients that were supposed to benefit from chemotherapy, we introduced during the waiting period progressively increasing number of cycles of FOLFOX. What we observed here was that the PCR rate that in the standard treatment, chemoradiation with surgery at approximately 6 weeks, was 18%. When we lengthened the interval to more weeks, getting chemotherapy during the waiting period, the pathological complete response went up significantly, up to 38%. What we couldn't tell whether the increase in the pathological complete response was due to the longer waiting period, to the chemotherapy, or to both. But the fact of the matter is that if you give chemotherapy after chemoradiation and delay the time of the surgery up to 26 weeks, the rate of pathological complete response goes up. And the reason why we did this study, because we were thinking in eventually studying organ preservation and stop doing surgery in that 38% of patients. So this was a study that was done prior to the OPRA trial, and it was a preparation for that trial. Now, other investigators in Europe and in Asia, they have used the idea of, in this case, short-course radiation followed by consolidation chemotherapy, and compare that with the standard chemoradiation followed by surgery and then chemotherapy. This study in Poland shows slightly increased, but not a statistically significant increase in response rate when you use chemotherapy after short-course radiation, but the survival curves were exactly the same. The same in the Stellar trial that was conducted in Asia, similar design, short-course radiation followed by chemotherapy versus chemoradiation. In this case, the difference in response was a little bit higher, but no difference in survival outcomes. Now that brought us to the Rapido trial, which probably you heard also a lot about, and I think you need to look at it with open mind and with a critical eye, because it's a very interesting study. It's a phenomenal piece of work with more than 1,000 patients randomized. And in this case, they randomized patients to the conventional treatment, chemoradiation, surgery, postoperative adjuvant chemotherapy, which was the control group, and then the experimental arm, which was a little bit similar to the Polis study and to the Stellar trial. Short-course radiation, 18 weeks of chemotherapy, they allow K-POX or FOLFOX, they considered an equivalent, and then surgery at the end. The response rate went up from 14 to 28%. This study is a little bit complex because they use an endpoint that is similar to DFS, but not exactly the same. It's called disease-related treatment failure. And again, what they found was also difference between both arms. But as you can see at the bottom left of the Kaplan-Meier curves, in the disease-related treatment failure, the difference in curves happened very early on, in the first few months, even before the patient received surgery. And then the curves ran completely parallel. Statistically, the difference in these curves is significant. But I think also that bump in the standard group, in the number of events, is also questionable. In this study, the overall survival is exactly the same, no difference in survival. So again, something just to keep in mind. Now, toxicity, similar to the PRODIS-23, the more chemo you give, the more toxicity you get. Because the experimental arm got chemotherapy, and in the standard arm, they allow chemotherapy at the discretion of the treating physicians, and only half of them got chemotherapy. So the toxicity was half. So something that is important is to analyze what happened when we give chemotherapy before surgery in these patients, and then in some of them after you give chemotherapy or not chemo. It's important to look at the patterns of locoregional recurrence and what happened when you develop this locoregional recurrence. In this particular study, the rate of local recurrence was higher in the experimental arm. We don't have a very clear explanation why it was. Maybe the short-course radiation was not as effective as the chemoradiation, killing cancer cells. People claim that because the surgery was performed so much later, the total mesorectal excision was more difficult and maybe was not as complete as a result of the long waiting period in the experimental arm. Again, it's not a very clear explanation, but the local recurrent rate was higher in the experimental arm. The other thing that was interesting was the survival after local regional recurrence. So the patients in the experimental arm had lower rate of recurrence. The standard arm had higher rate of recurrence, but the survival rate was not significant. Now, when it comes to distal metastases, they were becoming interesting. The distal metastasis in one group was 23%, in the standard was 30%. But the survival for patients who were in the experimental arm with less rate of distal metastasis, it was much shorter than in patients who had, the standard treatment and receive chemotherapy later. And this is an interesting paradox that has been described as the chemotherapy before the patient had the surgery kind of primed the tumors to be more resistant if the tumors come back. In the group of patients treated in the control arm, many of them did not receive chemotherapy. If they develop metastases, those metastases are going to see chemotherapy for the first time. They are kind of treatment naive, and their response to the chemotherapy is better. So sometimes we get surprised by findings that no one expects when we design the trial. And this is probably the explanation why, even though you might see more metastases in the experimental, in the control arm, because they are more likely to respond to therapeutic chemotherapy if they develop metastases, the survival rate between groups is exactly the same. So I think that's something to keep in mind when we talk about all these treatments. So what have we learned from the Rapido trial and from the other trials? That, there was a greater rate of response in the experimental arm when you give so-called radiation followed by chemotherapy. Delaying surgery might reduce the quality of the mesorectal excision, and that's why patients might have a greater local recurrence rate, we don't know. And then there is the issue of the lower rate of distal metastasis, but shorter survival after developing metastasis. Again, this is just a speculation because we don't really understand why that happens. So chemoradiation and consolidation chemotherapy increase the rate of response, improve compliance with systemic chemotherapy, maybe reduce the rate of distal metastasis, but do not improve survival. I think after having looked at the survival curves in those two studies, it is important to look at the survival curve in patients with colon cancer treated with 5-FU and oxaliplatin versus 5-FU alone. This was a landmark trial in the early 2000s, the Mosaic trial, a very large study with 2,500 patients, more than 1,100 in each arm, and they proved that adding oxaliplatin to fluorouracil was better than fluorouracil alone, both in DFS and overall survival. But I want you to look at the curves and how the curves separate in this case. They separate slowly over time, and the separation kind of increases with time, which is quite different than what we have seen with the PRODIGE 23 and the Rapido trial. So that's the reason why it is important to look at the details and not just at the abstract. And you see what I was mentioning when he talks about the probability of DFS, how the curves in these studies compare with study that is a landmark in colon cancer. And this is important just to keep in mind, what are the important outcome measures in rectal cancer trial? We have used DFS, and we have used tumor response. And I think we have to keep in mind that at the end of the day, the most important thing is overall survival, because that's the most objective defined endpoint and the standard measure of efficacy in treatment. The problem is that you need a lot of patients to use overall survival as an endpoint, and you need to have a significant follow-up. That's the reason why we try to use surrogates of efficacy, such as disease-free survival or response. They are very useful in the design of the trial. But establishing surrogacy, saying that DFS is equivalent to overall survival or that response is equal to overall survival, requires two levels of correlation. You need to do it at individual endpoint surrogacy and trial level. And this is a major task. That has been done in colon cancer. This is also a landmark paper when they compare if DFS translates into improvement in overall survival in patients with colon cancer. And they were able to do it looking at the data of 18 randomized trials. but that hasn't been done in rectal cancer. So when we hear things about rectal cancer, we have to take the data with a grain of salt and be critical about how the data is generated and what it really means. These studies are important, but we cannot take them for more value than what they have, okay? Also, it's something important to keep in mind when we talk about total neoadjuvant therapy, that has been tried in other tumors, and it has been found to not really improve survival that much in esophageal, lung squamous cell carcinoma, and particularly also in breast. You have differences in distal metastases, but no difference in distal metastasis or overall survival, death for any cause. So I think the idea of neoadjuvant chemotherapy is important, increases compliance, and it has some potential benefit, but we also have to understand the limitations. We have to keep in mind that everything that we do has side effects, and we have to make sure that they're going to benefit the patient in one way or another. There is one study that has tried to compare both ways to deliver the total neoadjuvant therapy, chemo first versus chemoradiation first. This study, addressed that issue. The only problem is that only delivered 3 cycles of FOLFOX as opposed to 8, which is more standard in total neoadjuvant therapy in the United States. What the study found was that starting with chemoradiation seems to increase the rate of response compared to starting with induction chemotherapy, but the disease-free survival between both arms was the same. And this is something also to keep in mind. The rate of response for the entire group doesn't have any impact on survival. The patient who had a pathological complete response, they have better survival than those that they don't. But when you look at both groups aggregated, the survival is the same. And that's the reason why this study shows that in both arms, with different response rates, the DFS is exactly the same. We can talk about that another day. So, follow the idea of improving the quality of life of the patients, we pursue the OPRA trial, which was intended to see if that 38% of patients that we have identified in the timing trial, we could eliminate the total mesorectal excision and with that, all the morbidity associated with the operation and the long-term functional sequela. And we came out with this design. We wanted to get patients with distal rectal cancer, tumor that they were in the lower part of the rectum. We randomized them to chemo first or chemoradiation first, so 2 different forms of total neoadjuvant therapy. We thought that was a good opportunity to compare both of them. Then, so they got chemoradiation followed by chemo, or chemo followed by chemoradiation. At the end, we did the restaging, and we stratified the response. Incomplete response, we look at the rectum, cancer is still there, we take them to the operating room, or we look at the rectum, the tumor is gone or is almost completely gone, and then we offer those patients watch and wait. Of course, this design is not perfect because we don't have a control arm. No patient will agree to be randomized to surgery versus no surgery, so we have to use historical controls. The endpoint was disease-free survival for the patients treated with TNT and watch and wait. The hypothesis was that if we introduce watch and wait in the treatment paradigm, the overall survival of the patients, the survival for the entire group will be similar that if we use standard, including chemoradiation, TME, and chemotherapy. Then we have secondary endpoints, such as compare the 2 different arms and other measures. There was a study in patients with stage 2 or stage 3 rectal cancer. We required that they were patients with distal tumors, a tumor that will require an APR or a coloanal, and the treatment were standard treatment. 4 months of FOLFOX or CAPOX, standard chemoradiation with sensitizing chemotherapy during the radiation. Again, half of the patient got chemo first and chemoradiation second, half of the patient got chemoradiation first, chemo. And of course, because there was a multi-institutional study, we had to agree on what we call a clinical complete response using endoscopy and MRI, what it was a near complete response, those patients that the tumor was almost gone but not completely healed, and the patients that we call that had an incomplete response. I think as you can see, patients with incomplete response, the tumor had responded, but just by looking, you could tell that there was still some tumor there. In the middle picture, that's what we call a near complete response, a very superficial ulceration with fibrin or some nodularity, but really you couldn't tell that there was tumor there. Now, a complete response the tumor is gone. There is a nice form, white scar with telangiectasia and just no evidence of ulceration or nodularity there. That was the criteria that we used. And then we follow this patient regularly. During the first 2 years, we follow the patients 3 times, and during the subsequent 3 years, we follow them at least twice a year. We, did the MRIs twice a year and then once a year, and then, of course, the chest CT in a yearly basis and colonoscopy as per standard guidelines. And, these were the characteristics of the patient. As I say, they were patients with a stage 2 or stage 3 disease. Most of them were stage 3, and they were very distal. The mean distance was 4.3, 4.5 centimeters. And this is what happened. At the end of the total neoadjuvant therapy, when we did the assessment at 8 weeks, 75% of them went to watch and wait. Of course, when we follow those patients for years, we saw that some of them developed tumor regrowth. And the rate of tumor regrowth was higher in patients who got the chemo first compared to the one who got the radiation first. Like you can see, most of the regrowths occur in the first 2-3 years, and then the rate kind of plateaus. There's only one patient who got a tumor regrowth beyond year 4. And in this graph, we represent the proportion of patients who were TME free. So these are patients who preserve the rectum long term. You can see at the beginning, some patients require surgery, and at the end of the day, a little bit more than half of them in the chemoradiation group first, and a little bit less than half in the one that chemo first, preserve the rectum long term. The accuracy of the imaging studies is not perfect. It's not perfect when you look right at the time of restaging or during the follow-up. Endoscopy seems to be better than MRI. Radiologists might not like that, but this is what it is. I mean, most of the regrowth occur inside of the bowel wall. You can see them with endoscopy. So that's the reason why the endoscopy is better to pick up regrowth than radiation is. But this is still an area that we need to improve because, again, neither one of them is perfect. And that's the reason why the issue of the watch and wait is not just one time point, is following the patient. If you have a patient with a near complete response, what we do, if we have a patient with a near complete response, we have them come back in 6 weeks and we look again. If the near complete response is moving towards a complete response, we keep on watching. If the near complete response, the ulcer and the nodularity is stable or is not progressing towards a complete response, the patient needs to have surgery. But we hope that there will be advances in endoscopy and imaging and maybe new technologies, ctDNA, to help us really better select the patient for organ preservation. In this case, the DFS and the overall survival are no different between groups. Local recurrence, distal metastasis, no different between group, and probably what you expect with a stage 2 or stage 3 rectal cancer. When we compare the results, the disease-free survival of the OPRA trial with other rectal cancer trials that had included stage 2 or stage 3 disease, the results are not that different. The control arm and the experimental arms. The number that you see most often around there is 73, 76%. It sounds like for a rectal cancer, we are stuck there. And there is 25% of patients who die from disease, more likely from distal metastasis. And I guess that probably tells us about the biology and the relatively poor efficacy of our chemotherapy regimens. But what we try to say with this graph is that despite the fact that in the OPRA trial, half of the patients didn't have surgery for the primary, the survival is not that different from other previous trials. Of course, we don't have a randomized trial, and I think probably we'll never have a randomized trial randomizing patients to surgery versus no surgery, because I doubt that, at least in the United States, patients will agree to that randomization. So, we have compared this is unpublished data, the results of our trial that had the same design that the German trial that compared both induction and consolidation, and the DFS and the overall survivals are the same. So, probably, again, this is not, the OPRA is not a randomized control trial, but it sounds like we are not hurting patients by offering a watch and wait and having half of them avoiding surgery. What is important is that some patients had transanal excision. That was not allowed in the protocol, but some patients had transanal excision. And those patients were counting as having TME, because in the intention to treat those patients who had TME. Still, the other point is that in addition to the 50% that had a long-term organ preservation, we still have, 9% of patients that we took to the operating room thinking that they had cancer, they had a pathological complete response. So that's, probably the response is even higher. The problem is that we are not good at selecting them. The other thing that we look at, what happens of the patients that we did total mesorectal excision, either at re-stage at the time that we finish the total neoadjuvant therapy and we say this patient needs to go to the operating room, versus those patients who develop TME after having developed a regrowth during watch and wait. The survival seems to be similar. Again, this is not a randomized trial, but the data suggests that probably patients who can regrow, they are not hurt that much by having wait to have the rectum removed later compared to the patient who got TME at the time of restaging. Something to keep in mind is that, of course, in the OPERA trial, half of the patients didn't have any surgery. So when we look at the patients who have residual tumor after total neoadjuvant therapy, approximately 50% of them, these patients are a selected group of patients with biologically aggressive tumors. The rate of local recurrence is significantly higher than in trials that they include all the patients for obvious reason, because in our trial, half of them didn't have surgery, they never had local recurrence. So this is something to keep in mind when we are planning surgery for patients who have tumor that have not response to total neoadjuvant therapy. Those patients had a relatively more aggressive biological behavior, and we have to be mindful about that. We look at, this is data that we haven't published. Well, I think the paper was published this weekend. We compare coloanal and APR in patients with rectal cancer that had not response to total neoadjuvant therapy, and the risk of local recurrence with the coloanal was surprisingly high. So we are very concerned that nowadays, when we select patients for surgery based on the lack of response to chemoradiation, we have to be careful with local excision and coloanals, because we might find a higher rate of local recurrence that we observed in the past when we were doing surgery for patients who really could have been spared surgery. We have waited and given them the opportunity to respond. Now, one of the important things that we have learned is that the stratification predicts outcomes very well. Patient who got a near complete response at the time of complete response at the time of restaging do well. Patient who got near complete response don't do as well. They have a number of patients for regrowth. But when we look at DFS, the DFS is also stratified very well by the clinical response at the time of restaging. The patients who do the best are those who had the clinical complete response. The intermediate one are the ones that they have near complete response, and the one who do the worst are the ones who got an incomplete response. Remember, in the top group, 20% had surgery. In the middle group, 45% had surgery. In the lower group, all of them had surgery, still had the worst survival, because clinical response is giving us very valuable information about the biology of the tumor, independent of what we do with the primary. And this shouldn't be surprising, because when surgeons have looked at the survival based on the tumor regression, measured as the YPT or the tumor regression rate, a patient who had good tumor regression rate, of course, all these patients have TME, they do better than the one that they have poor tumor regression. Again, in this case, they were all patients who had TME. You can see that the curves are very similar to the one that I presented with the clinical complete response. So I think the clinical complete response is a very important predictor. It should help us decide for more aggressive treatment in patients with worse response. The problem is that we don't have any good way to treat those patients more effectively beyond what we have already done, which is the chemo and the radiation, the surgery. So what we have learned from the OPERA trial, the rate of response is higher than anticipated. We have obtained 50% organ preservation. Some patients who were initially entered into watch and wait developed tumor regrowth and required delayed TME surgery. Salvage surgery for most of these patients is effective in achieving tumor control. And that half of the patients treated with TNT ultimately preserve the rectum. And this is probably where TNT really is used, not as much as we thought in terms of improving survival for the entire group, is improving response, achieving organ preservation. It seemed like if you get the radiation before chemo and then, the assessment of response, the rate seems to be higher, and the organ preservation seems to be also better. And I think the survival seems to be equivalent to patients treated with the neoadjuvant chemoradiation, TME, and adjuvant chemotherapy. It seems like survival hasn't suffered with that approach. So originally we thought that because we were using TNT, we will improve survival, but that was not the case. The survival is the same. And, the survival is in the range of other clinical trials. Now, again, so I was trying to convince you that probably TNT is most useful to increase response and achieve organ preservation. But we had to keep in mind that there are more than organ preservation in rectal cancer. As I was saying before, there is the issue of symptomatic relief when the patient comes to clinic. There is the issue of the chemoradiation toxicity, the chemotherapy toxicity, fertility, and sexual, life issues, particularly in young females. So I think some patients might be better off with chemo first. And this is something that was also explored at MSK years ago. Dr. Schrack, who ended doing the prospect trial and is now the chair of the Department of Medicine here, did this small phase 2 trial in which she used 6 cycles of FOLFOX with bevacizumab in patients with stage 2 and stage 3 rectal cancer that were candidates for a sphincter saving procedure, a different population than the OPERA trial. And they give chemotherapy for 4 months, and then they did TME 6 weeks after chemotherapy, no radiation. So they were the first attempt to treat locally advanced rectal cancer without radiation. And the results were pretty good, very decent. There were only 27 patients, but they had 20%, 26% PCR, and the survival were very good. So this led to the prospect trial that was published last year, in which they had a control arm, the standard treatment, chemoradiation, TME, and post-op chemo, at the discretion of the medical oncology that was not mandated, versus an experimental arm that consisted on 6 cycles of FOLFOX, then reevaluation with MRI. If the patient had a good response, we'll go directly to TME with the possibility of more chemo after, depending on the medical oncologist. If the tumor had not responded to the FOLFOX, they will get chemoradiation and then TME. And again, these were still, similar criteria with some exclusions, tumor requiring an APR or low tumors. If the tumor was clinically T4, if they have more than 4 pelvic lymph nodes, or they were N2. So there were some earlier stage rectal cancer, higher rectal cancer that what we have, for example, in OPERA and in other studies. And, there was, again, a large study, more than 1,000 patients. These are the characteristics of the patients. Most of them still, or half of them, they were T3 and positive. There were some T2s and some T3 and negatives. And again, the tumor were 8 centimeters from the anal verge, much higher than the tumor that we had in the OPERA trial. The results was designed as a non-inferiority trial and met the goal. There was no difference in DFS. The chemotherapy fair were non-inferior to the chemoradiation, which were the standard treatment, the standard control. And again, this is the data proving that the non-inferiority was met. Overall survival was also very good, no difference. Local recurrence, staggering. I mean, this is just the local recurrence rate is single digits. I mean, look at the incidence, 100% to 98%. More than 98% were local recurrent free, which is quite impressive, probably reflecting that these tumors are high and they are earlier stage. The Europeans think that whether this patient need any neoadjuvant treatment at all. And that has been the main criticism of this trial. But this trial saw several important points, like there are at least 20% of patients who also achieve pathological complete response to FOLFOX alone, which is something that is important to keep in mind. Other trial, this trial in China, in this case, they had 3 arms, and they look at response rate. It was different chemo regimens, but the results were the same. Giving chemo before radiation or giving chemo alone, it had no impact in survival outcomes, including local recurrence. So, this is, a case, a patient of mine from a few years ago, 21-year-old female, rectal adenocarcinoma, MMR proficient, 4 or 5 centimeters from the anal verge, T3 and positive. You can see the tumor there. So what do you do with a 21-year-old female? Radiation therapy is going to affect her fertility for life. So in this case, we start with chemotherapy. And, after 4 cycles of FOLFOX, this is what we see. The tumor is almost gone, clinically and radiologically. And then 8 cycles, the tumor is gone. This was a number of years ago. So we were not ready to do watch and wait with chemotherapy alone. So we did LAR and coloanal, and the tumor was a YPT2 and 0. The patient is without evidence of disease and excellent quality of life years later. So this is just to emphasize that sometimes, even if you want to achieve organ preservation, there are other options in addition to starting with chemoradiation. So now, how we decide today to treat a rectal cancer patient? I mean, we have seen that you can start with chemoradiation, chemotherapy, and then potentially watch and wait. You can start with chemotherapy, then chemoradiation, and yes, then you can do surgery or maybe watch and wait, even though the results were not as high. Or you can start chemotherapy and then see if the patient is going to require, radiation or not. And I think that's going to depend in a number of factors. It's going to depend on the tumor, where the tumor is located. As you saw, different trials, they have different patient populations. The Rapid trial has a very advanced tumor, the Prospect trial, not so advanced tumor, the OPRA trial, very distal rectal cancer that will benefit the most from organ preservation. So I think you have to take into consideration location, size, stage. Smaller, early stage tumor respond better. We have found that EMBI is a predictor of response. Molecular profile, we are looking at that, but we haven't found really nothing dramatic that we can use, in practice today. But also you have to look at the patient. What is the age? What are the comorbidity, gender, symptoms? What are the goals and the expectation for the patient? So all these things need to be discussed because, again, the treatment of rectal cancer is not the same for everyone, okay? So that's probably the most important slide today. Now, a couple of words about patients with MMR deficient tumors. Only 4% of rectal cancer patients had MMR deficient, but I think with the patients coming at a younger age, we are seeing, at least in our environment, a lot of patients. There was a study aimed to treat them with dostarlimab, followed by evaluation, and then depending on the response, decide versus watch and wait or chemoradiation if there was a still tumor there, followed by the standard treatment, chemoradiation, and then potentially surgery or not. So, but the initial idea was we're going to give them dostarlimab, and we're going to see what happens. If there is residual tumor, we go to the conventional chemoradiation arm. If the tumor is gone, we just watch them. The surprise was that in the first number of patients, they all responded 100%. They all achieved a complete clinical response, and none of them required surgery or chemoradiation. So it was kind of a surprise result. And in this trial, at this point, we have already more than 50 patients, and the results still hold. I mean, the initial slide were the presentation at ASCO GI, they were the paper in the New England Journal of Medicine. And again, the study has continued, and the results hold exactly the same that they were reported at that point. So I think what I can say is that the treatment of rectal cancer has changed significantly. Total neoadjuvant therapy results in higher rate of tumor response and facilitate organ preservation, might reduce the risk of distal metastasis, although that has to be taken with a grain of salt, because many of the metastases were diagnosed in the imaging studies obtained during treatment, and it's not that clear that those metastases will have materialized in something, giving them more time. The issue of survival is still debatable. There is a debate now about do we de-escalate, such as the OPRA trial, or the Prospect trial, that Prospect trial got rid of chemoradiation, the OPRA trial got rid of surgery for some patients, or escalation, such as the PRODIS 23. We're going to add another drug to try to improve the results. So there is this debate in rectal cancer, and sometimes when you see the studies that they have been conducted, they are conflicting because one study is trying to do more and one study is trying to do less. I think there are no standards, but several standards, and I think we need to individualize the treatment. So I hope I did not confuse the audience too much. I don't know if we added some clarity. Of course, we always talk to try to identify molecular profiles to see if we can advance targeted therapies or immunotherapy, but that's not a small task. And a lot of people are working in the lab on trying to come up with new, more effective treatments. So thank you.
Great talk. Thank you so much for giving us that really great lecture. There are a couple of questions on the SurgeOnc chat. I'll ask the first one. This is from Matam Muslim. Do you think oxaliplatin is the problem as we see more resistant development these days, especially as we see in HIPEC? Would studying FOLFIRI in TNT and leaving oxaliplatin out be a considerable trial idea?
Well, I mean, I think, yeah, I mean, there are already some studies. I think the group in Sao Paulo is leading a study in Latin America where they are trying to get rid of oxaliplatin because oxaliplatin is causes significant neurotoxicity. So there's interest on that. I think in colon cancer, irinotecan replacing oxaliplatin was not as effective in the adjuvant setting. In the neoadjuvant setting, now, the study, the PRODIS 23, addressed that issue, but it was also including oxaliplatin, both oxaliplatin and irinotecan. There is now the Janus trial that is also comparing FOLFOX with FOLFIRINOX. But in the United States, there are not studies comparing fluorouracil and irinotecan versus fluorouracil and oxaliplatin. And it's a good idea because, platin is cause of neurotoxicity that, still affect a number of patients with rectal cancer. You get more as you get more oxaliplatin. You go beyond you go beyond 3-4 months, started to escalate. But even with 4 months, we see a fair amount of neurotoxicity in rectal cancer patients.
One of the other questions we had from the chat was from Dr. Narwal. Based on the literature with TNT, I think you touched upon this a little bit, but are the results better for chemo followed by chemo RT or chemo RT followed by a chemo?
I think not in terms of survival. I think the survival is exactly the same. Chemo radiation first followed by chemo seems to lead to more response and potentially organ preservation. So if you have a patient with a distal rectal cancer who is very interested in organ preservation, male 50s, 60s, 70s, or a female who has already passed the reproductive age, and the most important thing for them is organ preservation, probably starting with chemoradiation makes sense. That probably will be the group in which the chemoradiation at first is more valuable. Now, one of the things that we had to talk about TNT is that, it's kind of a strategy that you can modify as you go by. So you get chemoradiation, and what I do is I look at the tumor. Is the tumor gone or not? You start with chemotherapy and you look at the tumor. That's the advantage of the prospect trial. You do chemotherapy in a mid rectal cancer and you look, the tumor has responded very well to chemotherapy and the patient is not interested in organ preservation. Probably radiation therapy is not going to give you much more benefit and you're going to get the toxicity. So I think there has to be some degree of flexibility. So the decision when you see a patient with rectal cancer today, a patient who needs neoadjuvant therapies, what do I do first? If your goal is going to be organ preservation, probably start with radiation. If it's a patient that, of course, the tumor is higher in the rectum, or some patients don't want the uncertainty of organ preservation, then you start with chemo. And then after the chemo, you look at the rectum and see how has the tumor responded. If it has responded very, very well, both in the rectum and in the mesorectum, and you can do a resection with negative margin, probably radiation therapy is not going to help that much. So I think you have to keep in mind that, you don't buy the whole protocol the day that you see the patient. Of course, except you are in a research situation. But in practice, we have to be flexible and understand that tumor response to whatever treatment is a hugely important predictive marker. So, you have a big tumor and you give chemo and responds very, very, very well. That patient is going to do well. You have a tumor that you give them chemo and the chemo doesn't touch it, and the tumor is not MMR deficient, that's not a good thing because it tells you something about the biology of the tumor. So I think that slide where I show the prognosis based on the clinical assessment at the end of TNT is quite important because it's not only predictive that you are going to achieve greater organ preservation, but it's also prognostic long term. Those tumors, they don't metastasize as much. Those tumors, they are more likely to be cured. So I think it's something to keep in mind that, we don't have to give everything to every patient. We can always, be flexible, but we have to see the patient and examine them and, see them after the radiation or the chemo, whatever comes first, and then just, adjust the treatment according to what you see.
I think one question that I think is important is how long can you watch somebody to progress from a near complete to a complete clinical response safely?
Yeah, that's a very good question. I mean, I think the way the protocol was written was, the reason why we introduced this idea of near complete response is because we have studied how long it takes for a tumor to respond. That was all data from Prince Margaret Hospital in Canada from the 80s. And it took up to 8 months to some tumors to respond. So when we were designing the trial, say, how long should we wait? So we didn't know. There was no precedent. We decided, okay, after TNT, we're going to wait 8 weeks plus minus 4. At the end of the day, the median came at 8 weeks. So we came to that idea of the tumors that they are not gone, but they're almost gone. How long should we wait on them? And what we wrote in the protocol was, as long as the near complete is progressing to a complete, we can wait. If you see that the scar is not healing at all, or is starting to get a little bit nastier, you have to go to the operating room right away. So for patients with near complete response, we don't wait 4 months for the first reassessment after the initial one. We normally have them back in 6 weeks. And in those patients, what I do is the flexible simidoscopy, not always the MRI, but at least the flexible simidoscopy. If the ulcer or the irregularity is getting better, then I wait another 6 weeks until it's completely healed. But if there is any doubt, we take them to the operating room. I mean, in the OPERA trial, 9% of the patients went to the operating room and had a PCR. We're probably some of those patients that we felt, okay, this patient needs to go to the operating room, and we were wrong. The tumor was gone. But I think it's safer to take the patient to the operating room and find out that the patient has a PCR than, having the patient coming back 6 months later with a big regrowth. You want to treat the tumor when they are responding. So it's just common sense, and be willing to see the patient as often as needed. I mean, you don't want to see him every week, but an interval of 6 weeks is reasonable. And I think that's what we wrote in the textbook. Rodrigo and I wrote that chapter, and I think that's what we wrote, that for near complete responses, understanding what a near complete response is, which is also defined in the trial and in many other publications now, is just what I saw in that picture. It's just a small ulcer or something like that. All right.
A couple more questions in the chat. One is from Dr. Khalil. Does local excision following neoadjuvant therapy hold a place in your algorithm?
Well, I think it does when you start with a T2 tumor or less, when you start with a T3 or lymph node positive, and you have a non-complete response. An incomplete response is risky because you don't know where the cancer cells are. We have a paper published a number of years ago. There are some cases that you don't have cancer cells, very few cancer cells in the surface, and then you look inside and there is much more tumor scattered in the mesorectum, because the regression of the tumor is not linear. It's very scattered. So I think, we did the ACOSOC C6041 or chemoradiation and local excision for ultrasound T2 and 0, and the results were okay. But for stage 3 disease or for T3s or deeper, tumor that get into the mesorectal fat, I'm very skeptical about it. Also the other thing is that we look at the functional outcomes of the patients in the local excision trial in the ACOSOC C6041, and the functional outcomes after a local excision and chemoradiation, they are not great. These are patients with very distal rectal tumor. There were patients with tumors also within 7 centimeters from the alveolus. The median was like 4 centimeters. So you are right about the fintech. First of all, patients experience pain for months until the wound heals, some of them, because when you have a local excision close to the anus, it's painful. And then the functional outcomes, you cause some scarring and deformity, and sometimes the functional outcomes are not great. So to answer the question, local excision after chemoradiation, maybe yes, for early stage tumor in the baseline MRI. I don't do it for T3s or M-positive tumor in a regular basis. They either had a complete response or they had TME. I don't like the local excision in those patients. That's my preference, but it's a big debate about it, okay?
Does it also make it harder to kind of surveil them? Do you see changes in their MRI?
Yeah, and the problem is that when you do local excision, I tell the fellows, and you might have heard me saying that, you open Pandora's box, because you are doing local excision expecting that there is not much tumor left. And then you get the specimen and they say the tumor gets into the perirectal fat and there is a an area of EMBI in the fat that you get into the specimen. Now, what do? Now you go do TME. In a very distal rectal cancer, probably you compromise and you eliminate the possibility of doing a sphincter saving procedure. Plus, also you have opened very often the circumferential or sexual margin. So it's complicated. I mean, I think if we had better imaging to really identify well the residual cancer cells, it would be a different story. But we are blinded. I mean, the MRI at baseline is not very good. The MRI at, after the patient had there is fibrosis and a scar, is not very accurate and deciding where the cancer cells are and where not. It's just going to the local excision a little bit blinded. So yeah, I will base my decision on the baseline MRI and only for early stage tumor.
Helpful. Dr. Maturi also asked, does tumor size as a determinant of response to TNT take into account the tumor length?
Yeah, I mean, I think in the studies we have measured the size of the tumor by the length because it's you can do that endoscopically, but also you can do that in the sagittal views of the MRI. Yeah, I think in general, early stage, smaller tumors respond better to any form of neoadjuvant therapy. Larger tumors, more advanced, they don't. The problem is that some earliest tumors don't respond and some very advanced tumors don't respond. So today we don't, I mean, I think for some earliest tumor you could do a surgery upfront without the need of any neoadjuvant therapy. But some patients that might have a small tumor but positive lymph nodes, you're still going to give them TNT, or neoadjuvant therapy. So yeah, it's an important predictor for sure, size and stage. So is EMBI, okay? EMBI, we have found that is also a predictor of poor response.
I'm sure we could just go on asking you questions all night, but I think we'll call it a night. Thank you so much for the talk, and we look forward to reviewing it later.
Yeah, sorry for the technical issue with my computer, but it doesn't allow me to show myself. Okay, so thank you, everyone.